Hello, hello, good evening, everyone. I hope you are doing well this season. My name is Leanne, Dr. Leanne. I'm one of the many PLAB educators on YouTube these days. I hope you are really studying very hard for this exam. Today, I wanted to do a little bit more of a focus on psychiatry or mental health. Okay. Now, I always like to start my sessions with a good word. So don't let your current struggle define you. You are an infinite possibility of so many wonderful outcomes. So I'll get right into it. If you haven't had a chance to watch my 5-day course, it can really assist you in preparing for this exam, not only the PLAB, but beyond. So that's what I do in PLAB strategies. I prepare doctors for more than the PLAB exam, okay? Because after the PLAB exam, you still need to be an effective, efficient physician, okay, a knowledgeable one. So as a supplement to what we're going to learn today, I want you to go back to the books. Watch other psychiatric videos. There are fantastic teachers out there doing a good job teaching evidence-based medicine, okay? So let me just put myself in the usual position way up here. Okay, and then we shall start. Okay, psychiatry is quite challenging and many people don't know how to manage mental health. We all suffer from mental health problems or we may suffer from it at one point in time of life, be it anxiety, being it depression. Some may suffer it a little bit more than others with panic disorders. And you have to be very, very sensitive whenever you're dealing with a patient who has mental illness, okay? You don't want to come off as a physician who is pushing the patient's, concerns away to the very end. If they're sitting before you and you can see that they are quite unsteady, they're sad, they're anxious, they're depressed, they are looking around, maybe they're hearing voices, or maybe they are seeing things that many people don't see or others are not seeing, or having hallucinations. You want to be very sensitive on how you approach them. That's why psychiatry is absolutely an independent specialty. And sometimes medics don't do too well with psychiatric illnesses because they want to focus on medical problems and then leave the psychiatric bit for the end. So if you're having a patient who's coming in and they're actively hallucinating, of course, yes, I would encourage you to check a blood sugar, do your vital signs. Could it be the delirium be caused by sepsis? Could the delirium be caused by a head injury or a cancer that has metastasized? Yes, you can do that, but don't make the whole consultation about medical investigations. And if you are in an exam setting and you do that, you will lose points for management. You need to know how to manage psychiatry as a psychiatrist. So, and this is one thing I teach my doctors, I say, you need to know the setting. If you're a medic, think like how medics think. If you're in pediatrics, what questions do pediatricians ask? If you've watched some of my videos, I say they're mostly focused on milestones, vaccinations, and what have you. If you're in obs and gynae, what is your focus? Are you focusing on arthritis and joint pain and hair loss? So you see, so you really have to show good capacity. It's one of the words that I'm really throwing around. Doctors need to show that they have good insight and capacity when they are treating disease. You just don't come in like Dr. Rambo throwing all these questions, not waiting for the patient to answer. Psychiatrists usually start more with a social approach. Okay, they're not coming in asking about medical conditions and allergies and family. No. You have to really train yourself and even study to show yourself approved in this field of mental health. Okay, so let's get right into some of these common psychiatric diseases in the NHS. And maybe it might be better if I put myself right in this other corner. Now, is this an exhaustive list? No, absolutely not. But I want you to see the range of diseases that can come in psychiatry, all right? First world countries, mental health is usually one of the top 3 causes of disease. So you may have cardiac disease, you may relate it to obesity, but don't forget depression. especially during this season where people are losing jobs, they're losing their loved ones, they are restrained in their homes, they're all on a lockdown. There's only so much Netflix that you can watch, especially people who are very active in the community. So as part of maybe your other cases when you're dealing with a patient in the NHS, it's always good to find out how are they doing. Stepping aside from your regular background history of presenting disease, take a step back and just ask the patient, how are you doing this season? Okay, mental disorders in children are increasing as the days go by. Let's look at just this list: suicide, mania, hypomania, okay, panic disorders, agoraphobias, separation anxiety disorders. And you have to know also in pediatrics, for example, if a case comes to you and the patient is saying, oh, my child, was very friendly, doctor, when they were young, and, they would accept to be held by, my relatives, but now they're very withdrawn. Do you think somebody's abusing them? What is the critical question you'd want to ask in such a case? The age. In that age of 9 to 12 months, these kids have separation anxiety. So it's a normal thing. Okay, so you also have to know milestones whenever you're dealing with mental disorders among children. Okay, look at OCD, post-traumatic stress disorder. Non-accidental injuries are more common than we think. I don't want you to be the gullible physician because a mother is sitting in front of you crying, saying that her child has started wetting the bed again after having a period of dryness. Oh, I don't know, I think my child is just, she's just stressed. She could be the culprit. She could be the one who is abusing the child. A child who's coming in and they've suddenly withdrawn, they're regressing. Okay, there could be NAI, maybe not outside the home, but inside the home. Okay, and honestly, research and evidence has shown that the worst perpetrators in abuse are the people who you least suspect. So that's just something to broaden your history taking when you're taking care of these cases. Substance abuse, alcohol use disorder. This is absolutely wonderful, especially if I was preparing the PLAB exam, especially now. I would definitely bring an alcohol use disorder. You're locked up in the house with nowhere to go 7 days a week. Okay, you can have Tesco and Morrison's deliver for you a crate of alcohol without even asking. Substance abuse disorder. Do you think the ones who are dealing with drugs have not invented new ways of supplying, to their clients? You have to ask all these things. Tourette's. What if somebody comes in and they says, my child is really behaving very badly. Every now and then they're cussing and they're saying all these words and they're having tics. So this session today is just as a guideline for you to now go into the books and research. Go into the NHS website, nice guidelines, and type in all these diseases and make out a list of the treatments, the management, what to ask for. Okay? Conduct disorder, amazing. In adults, okay, so you have MDD, your major depression, we'll talk about that today. Suicide, we'll talk about. Panic disorders, social phobias, someone who is having panic attacks every time that they want to give a Zoom meeting. Oh, doctor, my name is James. I've come into the GP clinic today because every time, I have to present to my peers, I'm really feeling very sweaty. My arms have a bit of a tremor. I can't focus on the screen. I know I'm supposed to look at where the light is shining on the computer, but I keep freaking. What is that? Okay, is it a social disorder? Is it a panic disorder? Of course, you want to go through the steps of asking, when did this start? Is it because of a location setting? All right, and I know I'm talking very fast, so you may have to slow it down a little bit. I do like psychiatry, although I don't practice it. I like where the action is in surgery and in the acute medical units and ED. That's why I feel like my heart is beating for medicine. But, kudos to you if you really enjoy psychiatry, because I think it takes a special type of personality to have the patience to sit down and talk to somebody. Maybe initially they don't want to open up to you. You have to be patient. in an exam setting, they could have told that simulator, be quiet for 1 minute. Let's put the doctor in a hot seat. Are you going to panic? You know, you're going into a patient and saying, hello, my name is Dr. Lian. I'm one of the juniors in the psychiatry department. You know, it was brought to my attention that today you took, you know, a whole bottle of paracetamol, and the patient is just there, not talking to you. So what do you do? Why? What do you do? You have to start at a different angle. Okay, so if you try to medically assess a psychiatric patient, you may not go anywhere. You may actually have to start with a different angle of, you know, James, how did your day start today? Or Samantha, how did your day start today? How did you come to our psychiatric clinic? How have you been doing? You know, okay, social first, you can always try. Anorexia, easy stuff. Bulimia, general anxiety disorder, antisocial personality disorders. So this is just some of, not a comprehensive list, but just something I just literally picked from the NHS, okay? Then you have your personality disorders. Borderline personality, avoidant, dependent, schizoid, I'm missing a C there. Paranoid personality, OCD, woman has come into the hospital and her hands are red and bloody and infected because she washes her hands every 5 minutes. Samantha, I can see you're a bit uncomfortable even with this conversation. All right, how often do you use or how often are you washing your hands? Every 5 minutes. Right now, are you feeling the need to wash your hands? I can just see that your hands are quite excoriated. When you wash your hands, what are you washing your hands with? Okay, so let's actually do this case. You are the FY2 in the GP clinic. Samantha Jones has been brought in by her husband because she has a hand infection. Assess the patient and address the concerns. Or the husband has brought in the patient because he thinks that she is having a hard time coping. Or Samantha Jones herself has come into the clinic because she has concerns. You can twist these cases a million ways. The management is really going to be dependent on how good of a history-taking doctor you are. So these are some of the skills you really, really have to hone in on. If you don't get the story, you will not be able to manage. And I teach this in my classes. I say, if the task is make orange juice, and you go outside and start collecting apples, even though you bring a whole truckload of apples and mangoes, you will fail the case. Why? They want orange juice. So stop collecting apples and bananas and saying, no, I will make apple banana juice. I'll make a smoothie. Nobody cares. And that's when I talk to doctors who failed clinical exams, OSCEs, and medical students who are having a hard time passing clinical exams, honestly, sometimes it's a little bit like a cognitive behavioral therapy, because there is a part of their personality that is so rigid and so fixed. You cannot be a doctor like that and succeed. You have to learn how to adapt. Okay, even in such a way that you could be talking to a patient and they latch out, and your reflexes are good enough to make you miss that blow. Doctors have to be adaptable. You have to learn how to dance, okay? And dancing with your words, okay? Listening also, incorporating these communication skills. I won't get into that too much because I've given you guys enough free videos to go and read and listen to, and enough information for you to pass pretty much clinical exams, okay? So now, OCD, Samantha has come in, she's 45 years old. She's saying, I know I have a problem. Look at my hands. Okay, look at the hands. Let me take a quick look at them. I will do a focused examination at the end of this, but I just want to make sure that you're not bleeding at all. Okay, how long has this been going on for? When did it start? Was there a trigger before you started feeling the need to wash your hands? Yes, doctor. I went to a place and I touched a frog. Or I just started feeling like my hands are very dirty. I don't know where I went to. Or I'm just obsessed that COVID can be caught by touching objects. And you know, the virus can lay active on a surface for a couple of hours. So I don't want to catch COVID. You see, there has to be a trigger in mental health. That's one question you have to ask. Okay, because people are usually not born with mental dis-ease. Okay, look at it. Age 1, age 2, age 3, age 4, age 5 is now when we start seeing most pediatric psychological diseases, pediatric psychiatric diseases. Okay. There must have been something that happened. Now, if you are in your clinic in the NHS and you have a whole day to talk to 2 patients, of course you can do a history from here to Spain, okay? But if you're working with 10 minutes or if you're working with 8 minutes or a 15-minute station, you have to narrow down that history taking, okay? You have to add your differentials and then move it on. So Samantha, I would ask Samantha, what is the trigger? If she can't remember the trigger, then let it go, okay? But she's now here, she's washing her hands. When did she start? 3 months ago, okay? She's washing her hands. How often? Every 5 to 10 minutes, I'm washing my hands. How are you washing your hands? I'm washing them with water and I'm pouring bleach on them and I'm scrubbing and excoriating them. Now, are you doing this because you can see that your hands are dirty, or do you feel like they are dirty? So you have to assess that. Is she seeing little animals crawling on her hands? Is she seeing mud spots? Okay, so you have to investigate that. All right. And have you seen a doctor with because of this condition before? No, doctor, this is the first time I'm seeking help. And then people throw in that bogus question. Do you have any idea about what is going on? What do you expect us to do? Please be very careful with ICE in psychiatry or in mental health. Most people don't have an idea why their brain is thinking like that. Okay, so you have to be careful. ICE has its place, ideas, concerns, and expectations. But you being in the medical field for as long as you've been in the medical field for, you should know concerns. If you ask the question, the concern of the patient, you can probably hear the idea or the expectation infiltrating. So it will save you time in an exam setting, okay? Now for Samantha, what would I want to do? She's come to the GP, okay? Are these hands infected? You want to assess them. You want to check your pulses, okay? If there is excoriations with pus-filled wounds, send a swab to microbiology. Give her pain medication, okay? See if you want, you can bandage the arms. And then what? Refer. So why people don't do well in such a case is because the first thing they want to do is you have obsessive compulsive disorder. Do you know what that is? There is an obsession and there's a compulsion to relieve the obsession. So your obsessive thought is your hands are dirty and your compulsion is you want to clean the hands, okay? Yes, you can say that, but can you first treat the problem that you're seeing at hand, okay? I won't get into too much, I have explained, I think, how to do a good history taking on my previous video of common diseases in the NHS. If you're looking for a good template on how to understand disease and how to do a good history taking, do yourself a favor. Or open the foundation book and study. Open a medical book and study. So now, good, you've done your history, the trigger. You've found out, maybe she had a psoriasis, underlying psoriasis. Does she have acne? Does she have any lesions anywhere in the body? Extensors, flexors? Is it in the groin? Okay, so you can throw in just a few medical questions, but not the whole book. Okay, does she have any allergies? Just to rule out, was this caused by food? Okay, was it caused by a change in soap? But it's clear, she's washing the hands every 5 minutes. Okay, now, how do you manage? Let's check first her pain level. Let's give her the pain medicine. Let's bandage the wounds. Let's send for microbiology or cultures for any wounds that could be draining. Okay, let's find out if she has support. And then now you can explain to her what is going on. Samantha, you're having a hard time. And from your history, from what you have told me, it seems that the trigger that you had with COVID, by catching COVID by, touching a surface, you're still thinking thoughts that you could get an infection if you don't wash your hands. Washing hands is good. Okay, research shows at least washing your hands before you touch your face and not constantly touching your face anyways, okay? Washing your hands before you eat. Washing your hands when you get into a new setting. So for example, every time you leave your house and you come back in, it's always good to wash your hands because you don't know what you've touched. But it doesn't mean that washing your hands every single 5 minutes is going to keep you free from bacteria. In fact, now you're getting rid of normal flora or normal bacteria that can even protect you against further disease, okay? So now what can we do about this? All right, we've identified this trigger. Can we refer you to a specialist who can explore in detail, okay, why this is happening and maybe any other reason that maybe we do not have the time to explore here, okay? Sometimes they can give you sessions to sit down and talk to them and try and break this cycle of the obsessions, okay? Because that's what it is. She is obsessing, okay? And then the compulsion is now to relieve the obsession. She could come in with obsessions of checking the door 3-4 times a night because people broke into her house and stole her TV, okay? So now, why I'm bringing this case so early during this training session is because I don't want you to be the doctor who refers to psychiatry in the first 2 minutes of management. Do your job first, find out what is going on, and then you can have a consultation with the rest of the team, with a senior doctor, and then now you can refer. The referral is 2 sentences. We'll refer you to a psychiatrist, or we'll refer you to a counselor, or we'll refer you for talk therapy. For what? We just don't refer people to shrinks, okay, to psychiatrists. Sorry, the psychiatrists who are watching this session, okay? We just don't refer the patient and just leave it at that. What will the psychiatrist do? They will try and engage and see the trigger factors, how to stop them. And sometimes they may be able to supplement some medication according to the progressive nature of the disease, or if they think it's severe enough, or they can just continue going on with the cognitive behavioral therapy, okay? Now what will you do? Because is she going to go to the psychiatrist tomorrow? No. The waiting times in the NHS, are ridiculous. You need to give her coping strategies. So in the meantime, while I try to get you an urgent appointment, there are a couple of things that you can do, okay? So I would like you to have, if she lives with her husband, can her husband help her to cope? If he sees you getting anxious, okay, is there if you rewind it back a little bit, let's start from the beginning. What do you do when you start feeling? I want you to start noticing the times you get anxious or you start thinking that it's time for you to wash your hands, okay? Every time you walk into the kitchen, do you feel like you need to wash your hands? Then I would want you to maybe reduce the times that you're near the kitchen, because the kitchen is a trigger. The tap is a trigger. Okay, would it help if you wore some gloves, because then that can prevent you from thinking that you're acquiring an infection? How about wearing some temporary gloves when you're walking around the house? That way you can trick your mind that you're not getting infected. Okay, can your husband assist you in this so that he can guide you in terms of making you aware that you are washing your hands 3 to 4 times a day? Okay. People have mentioned to me, like in one of my mocks exams, or can they put an alarm on their phone, to give them targeted times, like, okay, I will not wash my hands in the next 1 hour. Brilliant ideas. Okay. So expand your mind to think of ways that you can help this lady to to handle the obsession before she goes in for the evaluation with the doctor. Okay. Paranoid personality disorder, distrust and suspicious in others, motives are interpreted as malevolent, okay, dependent. So it might be a little bit challenging to bring these scenarios in a clinical setting, but please, if you're going to study a personality disorder, I would study OCD, okay? Now, just as a quick review, I literally cut and paste this from the PLAB website. Okay, because now my focus now is to train you for the PLAB exam. Okay, of course, we're not discussing any cases here, but I would want you to go and read what they have said about the examinations. They've given you wonderful blueprints with lists of cases that are fair game for PLAB 1. And those lists for PLAB 1, you can use them or superimpose them to help you study for PLAB 2. Okay, they've told you how a mock scenario looks like. Okay, you're in a mock consultation with a patient, a mock consultation. So whatever that patient is doing is acting. They have been told to act like they are paranoid. They have been told to act like a psychotic patient. Okay, played by a role player who has been briefed about their condition. You are what? A foundation year doctor, okay? You are told that your patient, blah, 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 all this has been referred to the GP. What is the examiner looking for? They want to check your data gathering, your clinical management, and interpersonal. So because I'm posting this on YouTube, I want you to be aware of what you are getting into when you're going to do the PLAB 2 exam. Okay, you have to know what is being recommended. They're giving you the answers right there and there. What do you need to demonstrate to pass? So in psychiatry, you need maybe to find a history of that acute presentation or chronic presentation, medical history of any medication that could have caused that psychiatric condition. Past medical history, your differentials, I've mentioned that before, okay? Make a diagnosis of a possible condition. They're not looking for you to make a certain diagnosis in 8 minutes, and they're not giving you any lab work or any answers to any physical examination that you've made. Okay, you have to conduct that consultation fluently and professionally. Sometimes the patient may be embarrassed about their disease and start giggling and chuckling. You can't be laughing and joking around with the patient and they're talking about maybe erectile dysfunction. So it may be the character is, he's breaking character as a simulator, but you have to remain professional. Okay, you can't be giggling and joking around in an exam. Okay, so anyways, I just wanted to put this here because I am putting it on this session for your training on YouTube. The doctor's office is familiar for you. The patient, okay, where the doctor sits, the doctor's table, okay, you have to know social impact, main concern, medical history. All this I've discussed in my previous sessions. Now, the psychiatric patient encounter, okay, again, chief complaint. If I was grading this exam and somebody came in and asked me just one question for past medical history, what's your past medical history? Do you have high blood pressure? Yes, I do. Are you taking any medications? I'm taking lisinopril. Okay. They've come in with, maybe try to think of something, delirium. Okay, they've come in, they're delirious. Okay. When did this start? Okay, are you on any medicines on lisinopril for high blood pressure? Okay. Do you smoke? Do you drink? Okay. Well, I want to do your vital signs, and then maybe you should stop taking some of the new medications you've started because they're causing delirium. I'll call my seniors and I'll refer you to a psychiatry for CBT. Do you think you will get maximum points by just going through a simple template like that? No. Psychiatry, as I had mentioned before, is a little bit different, okay? Now, you want to think in a couple of levels when you're doing your data gathering. Number one, their psychiatric presentation or their mental illness, is there a medical influence, okay? Is there a lifestyle influence? So now for psychiatry, you cannot avoid to ask people the question about alcohol, using of drugs, or recreational substances. You can't avoid that. Would you sacrifice a question like, have you traveled recently? Of course, because nobody's traveling now. We're on lockdown, okay? But could there be a medical background that is causing this delirium? They could have hit their head. They could have hypoglycemia. It could be as a cause of a stroke, okay? It could be sepsis. So you can't avoid asking a medical question in a psychiatric case. But your focus in psychiatry is not medicine. I hope you're really getting the drift that I'm throwing to you, okay? Now, if somebody is coming to you and they're telling you that, I want to kill myself, doctor, okay? Well, is your focus going to be on, before we talk about you wanting to kill yourself, I need to ask you about your medical conditions. Do you have any allergies? Do you smoke? Do you drink? You've digressed from the problem that they are giving you. And that is why the focus of the psychiatric encounter is that chief complaint. You must give it at least a good 80% to investigate why they are there in front of you at that time, okay? If at all there's one station or stations that really are dependent on your body language, your communication skills, your investment in the patient, addressing concerns, these are the interpersonal skills, is psychiatry. And it might be a little bit hard in an exam in this day and age. I'll have to get it. I'm not going to do a brief during this time, but can you imagine you have a mask on? So let me get my mask. You have a mask on and you're trying to show empathy and sympathy to a patient. So this is you, let me see. Samantha, I'm so sorry you wanted to kill yourself. That's why I like teaching the PLAB. This will make it really difficult, okay? If you're going to do a clinical examination, you'll have to wear a mask now in COVID. So are there any other ways that you can show your interpersonal skills while wearing a mask? Because look, how am I showing my empathy and my sympathy? I'm sorry you wanted to kill yourself. You can't. So now you have to use other parts of your body to show empathy and sympathy. Those of you who are monotone baseline, it might be a little bit hard. They can't see your smile. They can't see your worry. Maybe they can see your eyebrows, moving up and down. They can see your head tilting from side to side, your hands, okay? When you're showing concern, you zone into the patient, you lean towards them. But these are things you can't just start practicing on the day of the exam. You have to incorporate your body in your language. Okay. These are tough times, but people are still passing, and I'm still very happy at the passing rate that we are having. Okay, because now you're not only thinking about the exam itself and the medical part of it, but the other dynamics that can assist you to pass the exam. Okay. You have to think about these things. Even now, as you're practicing with your friends, can you practice with a mask on? Some of you, your voices, the tone is so low, you can't even hear them without a mask. How is the patient going to to hear you and they're sitting at 2 meters apart? You have to project, okay? You have to project. You have to practice facial expressions from here up, okay? Learning how to smile with your eyes, learning how to show sadness with your eyes, using your hands appropriately. Voice projection, okay? You can't speak very fast if you have a mask because you're going to, let me not get into physics, okay? You can't speak your tone has to, of course not being monotone, but your words have to be purposeful. They have to be projected, okay, at the patient. You can't be crunching your neck at the same time, all right? Watch the other videos, you will find all that information. Okay, let's get into our first case, depression. Why have I picked depression as the first case to talk in mental health? Because this is, in psychiatry, one of the biggest causes for psychiatric illness in the UK is depression, okay? And we're expecting these levels, unfortunately, to go up because of the circumstance. 73-year-old man presents to the ED because he has not been eating and is very isolated, okay? Daughter is concerned about his welfare. Talk to him and address his concerns. You are the junior doctor in the ED. 73-year-old man has been transferred from the care home. The care home staff have noticed that he's refusing to eat. His ambulation has decreased. He's not interacting with others in the care home. Okay. 25-year-old man has been presented to the ED because his roommates have noticed he's isolated. He's locking himself in the room. Okay. Maybe unfortunately he's trapped in this country. He can't go back home. Okay. He has to do the examination. Different scenarios, you can always twist them around. Now, an elderly person who has been brought in because of isolation and he's not eating, they're already giving you 2 criteria for clinical depression. Okay, so you go in, hello, my name is Dr. X, my name is Dr. Liang, I'm one of the juniors in this department. If the patient is there with the family member, of course, you have to introduce yourself to both parties. But this case is not about you to get information from a family member. Wow, what a big flop. You cannot get second-party information or third-party if the patient is right there. If they don't have capacity, then you can ask for the information from the one who is accompanying them. But don't be trapped to start talking to the daughter and the man is sitting right there. Or if the daughter is interrupting the situation and talking, every time you ask James, how are you doing? He's not been well. Okay, thank you, Samantha. When was the last time you visited the GP, James? He doesn't want to go to the GP. How is your mood lately? His mood is very late. Samantha, can you shut up, please, Samantha? What are you doing? In my country, that's what we'd say. But now, because you have to show, preserve that dignity and have respect, you have to say, excuse me, Samantha, I can really see that you want to help with, determining what is going on with your father, James. Okay, but I would really want to hear firsthand his perspective of what is going on. And then after I finish asking him the questions, I will come back to you and then maybe you can give me some of the input. Also known as butt out. Nobody needs your input now if the patient has capacity to talk, okay? And if you're in an exam setting, why did they do that? Why did they have a patient's family member interrupt you when you're consulting with the patient? Does it happen? Yes, it does. Sometimes we have to ask the families to please step out while we examine the patient. Okay, you need first-hand information from the patient. So James tells you, well, I just feel like I'm very down in the dumps. When did this start? Old cut. Okay, onset, location, duration, characteristics, associated symptoms, alleviating symptoms, aggravating symptoms, treatment. Okay, then now I'm going to mood. So he's telling me that this has been for the last 6 months. All right, and is there anything that happened before the 6 months? How was your mood before that? In a week, Monday through Sunday, how many days do you feel like you're really down? Like you really don't have the energy to socialize with anyone? Doctor, for, 4 days out of the 7 days. Okay. Are you noticing that your mood is better maybe towards the end of the day? Do you wake up happy? Okay, do you feel encouraged to face the day, or do you sleep feeling sad or with a low mood and then wake up with a low mood and it is still sad? Have you tried to, make yourself excited about life? These are the questions for psychiatry, my dear doctors. You have to switch into the psychiatric mindset because that's where the answers are. So now a nice way to fail is he's coming in and he's saying, I'm feeling very sad. Can you scale your mood for me on a scale of 0 to 10? 10 being the worst mood you have ever felt. And he says, maybe 5. Sometimes, and this might be a silly question, sometimes when somebody's mood is very low, they feel like killing themselves. Have you felt like harming yourself in the last couple of days? Oh gosh, please help us. You can't attack psychiatry like that. In fact, asking the question about low mood is not equal to suicide. Can you remove that from your mind? It's those crazy scripts that you're reading, and I know you're reading all those crazy scripts and following all those ridiculous recalls. You cannot survive on recalls on an examination, and you're a physician. You're too powerful to use somebody else's information. Burn them. Okay, go back to medicine. So now, James looks obviously sad. Can you mention that he does? You look sad, James. I can see that your head is a little bit lower down. You know, your daughter is very concerned about what is going on. You've mentioned to me that you're waking up sad, you're sleeping sad. I think you're depressed. How did you get to a diagnosis and you've not shown that you are trying to get any objective information? Okay. Now, where is my medical part coming in? Because in psychiatry, it's 80% psych and 20% medics, or maybe 70% psych and maybe 20% medics, and the rest is just, you know, social stuff. Yeah. You want to make sure that this depression is not being caused by a medical condition. Goodness gracious, is he eating? B12 folic level, vitamin D levels, I would have to throw them in. Is this depression being caused by thyroid issues? Okay. Is this depression being or change in his mood being caused by the initial prodromal, I like that word, prodromal symptoms of an infection? It could be. So do yourself justice to do differentials in psychiatry. Now, depression, you can diagnose depression clinically. And if you're going to give that a diagnosis in your exam, I want you to say, you know, ask SIGICAPS. This thing has been, honestly, I learned it all the way in medical school. In fact, there's another S over here. So SIGECAPSS, okay? So now, I need to ask you a couple of questions, you know, just to gauge, you know, where you are with, you know, feeling down, okay, considering everything that is happening. Of course, we still have to rule out any medical influence to your condition, okay? Now, how many hours of sleep do you get? 12 hours. Is this normal? Was this normal before the 6 months? No, before 6 months, I was sleeping 7 hours a day. Okay, so it has doubled up during the last 6 months. Yes. Okay. Is it that you're going to bed very late, or what time do you go to sleep? Because goodness, if he's going to sleep at 2, then of course he's going to sleep throughout the rest of the day. Okay. But don't get into the place where you're saying, how is your bed? How is the condition of the room? Is it too cold? Is it too warm? Okay. Do you notice that you're snoring in the bed, or has anybody told you that you're stopping to breathe during your sleeping? You've now digressed. You're collecting coconuts and you have been told to make orange juice. In a normal setting, would those questions be appropriate? Yes, but in this case, you're going to run out of time. Guaranteed loss of time. You won't be able to manage. So sleep, hypersomnia or insomnia. Interest loss. Has he lost interest? Or you can even ask, what are some of the things you liked to do, you know, before the six months, before you started noticing your mood is low? Have you lost interest in your reading of the books? Have you lost interest in watching your TV programs? All right. Are you being overwhelmed by guilty feelings? Are you feeling that your mind is just obsessively thinking of regrets or things that you should have done that you could have done and you didn't do? Are you regretting your life up to this point? Okay, so it's obsession with those guilty feelings. How is your energy level on a scale of 0 to 10, 10 being very energetic? Doctors can scale anything they want to do, okay? How is the scale of the food that I've cooked for you? How is the scale of the rice on a scale of 0 to 10? Is it bad? Okay. Concentration. When you start an activity, are you able to concentrate from the start to the end of that activity? Do you notice your concentration span has decreased? How long can you maximally concentrate for? 10 minutes? Okay. Appetite changes. Are you overeating or undereating? This is such a wonderful case for a patient who comes in and they're obese, okay? And now people are thinking that, oh, all obesity has to go through surgery. What if it's linked to depression? You'd have to, there's no amount of surgery that is going to remove a depression. Okay, so you have to think broad. Psychomotor changes are A nice way to ask them is, you know, when you wake up out of bed, do you immediately get out of bed, or do you want to just stay in the same physical or same position without moving much? Do you feel like you can't be bothered to get up and go to the couch, or get up and go and get the meal outside? You just want to stay in one position and not be disturbed. Those are psychomotor changes. And then now you can ask your suicidal ideation. Okay, so in the beginning, I would scale the mood, go through your SIGI cup, and then say, James, it seems like, you know, you've been having a hard time. Never say some people, when they have a hard time, they want to kill themselves. No, okay, you may want to ask it in a little bit of a wise way and say, you know, sometimes when things are quite tough, you know, you may find yourself between a rock and a hard place, or you may find yourself with no options, you know. Have you thought about harming yourself? Okay, or when you're really, really low and you feel like you don't have any way out, have you thought about harming yourself? I'm very sorry to ask you these questions, but it's important for me to know. Okay, now would you ask a homicidal question? Where would homicide come, honestly? Please, all right? But remember, as part of your management, you want to manage the things that could cause an acute state of depression, including your thyroid function test and doing a thyroid examination. It's absolutely okay. And you know where you are? You're in the ED. An ED doctor is not just going to refer somebody to psych, okay? Now, if he is a suicidal risk, absolute admission, okay? Now, we would like to refer you to psychiatry, and then down that road of talk therapy, they may start you on some medications, some SSRIs, or something to help elevate your mood. It seems that you have an imbalance of the hormones in the body. Sometimes we have hormones that help us to be a little bit happy, okay? So you may have an imbalance in your serotonin levels. Is there a way to assess serotonin levels? Depression is usually just clinical. So I don't want you to tell me in mock exams, I need to check your serotonin level. That's an expensive test, okay? Coping skills will help. You need to share your thoughts. What can you do between now and then? You know, I want you to set a target for yourself to at least get back the things that you like to do. Try and read at least one chapter in the book. Okay, sometimes really opening the windows in the house, maybe playing some good music can really help elevate your spirits, not isolating yourself, reconnecting with family members that you could be estranged from, you know, looking for hobbies. There are support groups, there are people who are still in isolation, but trying to interact with people through all this other media. That's where you go, guys. All people say to me when I do mocks, CBT. CBT, CBT, CBT. CBT is not the answer for everything, okay? And now, because you know, look at that, major depression is the first one. Then you have general anxiety. Then you have OCD, as I had talked to you about, okay? Then you have bipolar disorder. Now the thing is, with bipolar, you're having elevated and periods of depression. So that is why you want to ask about energy levels. Or in the whole week, how many times are you depressed? Do you feel like you're having spikes of energy and lack of sleep? Okay, elevated mood is significant and is known as mania or hypomania. Okay, again, the template is pretty much the same. But don't get into a trap of saying, if I can fix one psychiatric disorder, I can fix them all with the same template. It is patient-centered approach. Okay. Schizophrenia, there you go. I wouldn't be diagnosing schizophrenia in 10 minutes as a junior doctor, okay? Autism, again, neurodevelopmental disorder characterized by impaired social interaction, verbal and non-verbal communication. So your question asking has to focus on the verbal communication and the non-verbal things that this child is doing if they are indeed autistic, okay? Restricted and repetitive behavior. And to what extent? Are there triggers, guys? You can't afford not to miss triggers in psych, okay? ADHD, doctor, I want you to prescribe some medication because my child is very hyperactive. Okay, your child has ADHD. ADHD has to have an attention deficit and a hyperactive disorder. And it cannot be diagnosed only in one setting. It has to be diagnosed in 2 or more settings. So some of the questions you may want to ask about this case is, for example, I would pick up some of the questions from depression. Energy on a level of 0 to 10, how much is your child's energy? Is it always a 10 out of 10, 10 out of 10? Are there any triggers? Do you notice their energy is more increased when they are around people or around an audience? Is it much more of a trigger when they're outside in the public? And sorry, I'm asking you all these questions, Samantha, is because sometimes we have to really try and isolate or separate, you know, a normal child development with them being excited, you know, about life, or them trying to express themselves, and it being an actual disorder. Not all conditions of inattention and hyperactivity are ADHD. So you should stop trying to give these people medications and telling them to, you know, some of the things I would do for a child who is having ADHD would be, first of all, let's just make sure there's no underlying background. I would want to see the child, okay? And now before you refer them to a behavioral specialist, are there other things that you can teach this parent to do? You know, let's keep a diary of when you notice the behavior. Is it at home? Is it a specific time? Is it when they're out in the community? Is it when they're around somebody specific? Is maybe they're just happy to see their dad? Huh? Okay. And then first line medication is usually not medications. Okay, first of all, we would want to rule out medical problems, refer to the behavioral psychologist. They may do some screening tests, putting a child in a room, examining their play, okay, seeing when the inactivity is happening, timing their attention span, okay. They may do some other cognitive tests for your child just to make sure there's no underlying conditions, yeah? PTSD, substance abuse, really, really good. So I don't want you to, another big thing, I don't want you to associate psychiatry with CBT. That's not the only management for psychiatric illnesses, guys. You have to really expand that. Yeah, good, I'm glad I added this. Is CBT the only management? Okay. Fine, cognitive behavioral therapy, you're talking. Let's talk about it. Let's find out the trigger for this condition. Let's see how you can manage it. Let's give you coping skills about it. And I want you to think of coping skills, examples of coping skills that you can give the patient, okay? There are hospital and residential treatments. If you're a GP and you feel like this patient is having a hard time coping, a patient can tell you that I want to die, or they can deny the suicide question, but you can tell that if I let this one go, they're not going to succeed. What would you do? Let's see if they can have a 48-hour hospital admission on a psychiatric ward just to evaluate them. You can make, or a residential treatment. Okay, and a residential treatment, can we have one of our care team to come and check on you at home tomorrow just to make sure that you're doing okay? You know, can I check on you in the next couple of days to see how you're coping? Okay, let's have another session to see if you're managing these coping strategies that I'm giving you, because cognitive behavioral therapy does not mean that cognitive behavioral therapy is going to lead them back to their baseline health or 100% health. Sometimes cognitive behavioral therapy fails. And now if you have a patient, that's even a good suggestion. So let's say you are a psychiatrist, okay? You are told to evaluate Samantha Jones for depression, okay? She was diagnosed with depression 6 months ago. She has come in for a review of the depression. Hello, Samantha, my name is Dr. X. I'm one of the juniors in this department, okay? Thank you very much for coming in. I was going through your notes. I'm sorry, I can see you've been having a challenge with depression. Can we talk about it? Huh? Yeah, doctor, I'm depressed. Okay, when was this diagnosed? 6 months ago. Are you able to pinpoint on the reason why you started noticing that you're becoming, having a low mood at all? Yeah, my husband, he left me. Okay, why did your husband leave you? Wrong. You're going in a different direction. Okay, I'm very sorry. You know, was your husband only the closest person to you? Do you have any children? You know, and it's been 6 months. Did you start your therapies with us 6 months ago? Yeah, doctor, I came here, the doctor gave me medicine, I've stopped taking the medicine, and now I'm just doing therapy, talk therapy with Mr. James. Okay. How is the talk therapy? Is it okay for me to expound a little bit more on your on the CBT treatments? Okay. How many times do you go for CBT? How long are the sessions? Do you find them effective? Okay. What changes have you noticed, or what improvements in your life have you noticed after you started the cognitive behavioral therapy? Are you feeling like your mood is more improved? When you started the cognitive behavioral therapy, do you remember how low your mood was on a scale of 0 to 10, 10 being really bad? Yes, it was a 0. And now, you know, how are you feeling? I'm feeling like it's about a 3. And you've been having therapy for 6 months? It's not effective, guys. It's not. And now, is it not effective because she's not going for is she compliant? Do you go for each and every session? Do you stay through each session? In the sessions, do you feel like you're distracted at all? Are you able to focus? Because her depression could be she could be as thirsty as a camel that has walked in a desert for 3 days, and now you just want to give her a shot of water. It's not gonna work, okay? And so sometimes CBT needs to be managed with some medications, some psychiatric meds. Do you know your psychiatric medications other than SSRI? Oh my gosh. Do you know you can write 100 cases just from SSRIs. They've stopped taking the SSRI medication and now they're having a rebound. Or they've double dosed on their SSRI medication. Do you know side effects? Do you know serotonin syndrome? Do you know the NMS? What is that? I wish I was having an actual class, because then I would ask my good doctors in the session. There is a condition from it's a malignant syndrome. I'm going to put it in the comment section when I get it. Okay, there are side effects for antipsychotics. James Smith has presented to the GP clinic. Assess James, he has concerns. You walk in, James is doing this. Doctor, I don't know why. My hand just keeps going in this fashion. I don't know what's going on. Or, doctor, I am a painter, and I notice that every time I intentionally want to paint, I have a tremor. That is where psychiatry comes in. So I've been talking for maybe about half an hour now, but I've talked about maybe 20 cases. I hope you are not only listening, but you're hearing the message I am trying to speak to you. Okay? Please. Here and here. Okay? Now, psych meds. I would know first generation, I'd know second generation drugs. Okay? What if you have a patient who has come in from Kenya? You know, where we are still using those old antipsychotic medications that have all these tardive dyskinesia problems. Could it be Parkinson's disease? Okay. Could it be a withdrawal? Is he compliant? And that's another thing. If you are dealing with psychiatric medications or any medications whatsoever in any world system, be it USA, Canada, be it Australia, or it be the UK, you need to be at a level where you know what to do if you can't give a medication. Or, for example, a patient is asking you specific information about a medication. Aripiprazole, doctor, I need to know, is this the right dose? Do you know your resources? Your resources are drug books. Now you can tell where I put all my medical books. Drug books, pharmacy, your senior staff, okay? You need to be able to think a little bit outside the box when it comes to medications. If you're not sure about psychiatric medications, open a BNF and check, okay? Are you hearing the words that I'm telling you? Anyways, now, psych meds, I would make a list of psychiatric medications and side effects. Just be safe for this exam. Arts and creating therapies. I can see, James, you are having a hard time expressing to me how you're feeling today. You know, maybe it might be good if I can see who is on call today and we can have a combined session with a medic and a psychiatrist, or a medic and a counselor, or a medic and someone in one of our departments here to help you express yourself better with whatever is going on. A child has been brought in by the mother because she went for a camp, all right? And after the camp, she's no longer talking and she's isolated. Art and creative therapy will help that child to speak out, or to demonstrate, or to draw pictures that she was either abused in the camp. Okay, alternative therapies. Can you please signpost for, not everybody wants yoga and acupuncture. Who wants to be stuck in the eyes with a needle? This is going to make you feel better, Samantha. No, you have to respect boundaries, especially with alternative therapies. All right, there's some therapies that, you know, they're really not clinically based, but they've helped some people. Some of them include yoga, some of them are stress management, some of them are exercise, okay? Clinical evidence is not robust, but it doesn't hurt to try, okay? Self-care, family support, you are not your illness. And that's the big thing with psychiatry. It's such a good gauge of the type of doctor that you're dealing with. You really want somebody who is patient, okay? You really want to be able to use words of encouragement. And now I know, because I'm going to give you my psychiatric statement. I know now everybody's going to start using this statement. You have to modify it so that you don't sound robotic. You are not your illness. You are experiencing something that should not define you. Sometimes these conditions come with hopelessness, discouragement, and despair. I know tomorrow I will hear people in my mock telling me this when I bring them depression in the clinical lab, okay? Don't just cut and paste people's words. Put your personality into it. It will help you seem genuine. You can always know somebody who is faking it when it comes to words, because they stutter, they stammer, they are trying to remember. You are not your illness. You can come with hopelessness. What did Leanne say? This is not you. Anyways, let's move on. We don't have enough time. You're the SHO in the psych department. During intake, the patient mentioned to the nurse that she takes 30 units of alcohol a week. Assess the patient and manage appropriately. Do I see this almost all my rotations in the ED? Yes, I do. Alcoholism, especially during this time. Now, if you are in the emergency room and a patient has come in and they are an alcoholic, okay, would my question asking change to if I'm working in an ED department, I mean in a psychiatric department or in a GP clinic, and somebody has told me that the patient is an alcoholic? Absolutely, yes. You have to tailor your question asking to the patient. I am now in the psych department, and this patient, psych department, maybe they are stable. For them to be transferred to psych, they are probably medically fit. I want you to think that, but still psychiatrists can do a little bit of background with medical history, yeah? Now, this is a 100% alcoholic assessment. Why? Because of where we are. Hello, Jane, my name is Dr. X. I can read from the note that you take 30 pints a day. Get out of here. It's showing you are lacking capacity in how to do a history. Jane, my name is Dr. X. I'm one of the juniors in this department. Okay. I was just going through your notes, but I'd like to hear it from you. How are you doing? I'm doing okay, doctor. All right. During this season, how are you coping? You know, many people have many different forms of stress and different coping mechanisms. You know, I just want to find out how you've been managing the lockdown. Do you live alone? Okay, yeah. Are you able to work from home? Give me 12 points, examiner. How many people are asking that question? Now, tomorrow, everybody will be asking me, are you working from home? Then, and if not, how are you earning a living? You know, do you have support? Do you have financial support? No, I lost my business. You did. What were you doing? I worked as a florist, you know, making flowers for weddings. Oh, I really love flowers. And, you know, how long have you worked as a florist for? For 10 years. 10 years is a long time investment. Do you know about the programs that the government is giving to subsidize incomes, especially if you run a business? Maybe you can look into this. If you are struggling, is that in the medical books? No, it's coming from the heart, because now you're realizing this person, you know they are an alcoholic, but you're looking for a trigger without asking what is the trigger. That's now another level of history taking. That's where now the examiner stops looking at their phone and starts looking at you, because now, goodness, where did you come from? You are really engaging in the heart of the patient. Okay? So, you know, so it seems like you're having a bit of a struggle with, you know, with the lockdown and with COVID. You know, just a quick question. Have you been exposed to COVID at all? Do you know about the symptoms? You know, high temperature, coughing, changes in your taste and smell. Okay, just checking. I'm asking every patient this question during this season. Ding, 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 ding. Here and here, what I'm saying. All right, so I was going through your notes and something really stood out, and it surprised me. And actually it's leading to some of the questions that I have for you. How do you manage stress on a day-to-day basis? Well, I just try and watch some TV, or sometimes I manage stress with sleeping. Have you had any other recent stress other than losing your job? Well, no, I've just lost my job. Okay. And if I was to scale your coping level on a scale of 0 to 10, 10 being, you know, maximum coping, and maybe you're not coping at all and you're struggling to cope in the recent days, do you see how I put the scale in coping? You can do that. All right. Now, do you smoke? Once in a while, or what do you smoke? And we're in psychiatry, guys. In a medical case, would I want to know whether they're smoking cigars from Cuba and or hashish, all these other things? I don't care. In medicine, do you do drugs? Do you smoke? Do you drink alcohol? Let's move on, because you could be having a subarachnoid hemorrhage. Okay, but in psychiatry, I want to know what brand of cigarettes. No. What do you smoke? How many times do you smoke? Is your smoking related to stress? Do you feel a relief of stress when you smoke? Yes, I do. How about alcohol? You can't just ask somebody, do you drink? Do you drink what? Milk? Do you drink? Do you use alcohol or any alcoholic products? Yes, doctor, I do. What do you use? How many times a day do you use alcohol? When did you start using alcohol? As a teenager? Okay. About what age? I'm just curious to know. At the age of 16, we started drinking quite early. You know, was your childhood a bit stressful or troublesome? Yes, it was. Okay. Do you want to now go in and ask about the childhood and what happened and all these other things? You may not have time. Okay. Now, when you're doing an alcoholic assessment, please, and I teach this, I literally have taken this slide from my class and I've put it here, because an alcoholic assessment in psychiatry is more than cage. Do you feel like cutting back? Do you feel like anger is you're angry when people talk about your alcoholism? Do you have guilty feelings? And do you have an eye opener? In fact, because there are so many people who are taking these clinical exams now, can you, if you're going to use cage, can you call it, can you start with A? Can you start with G? Can you mix it up so that you can stand out? Okay, but I don't want you to talk about cage in an alcoholic assessment. Where is my slide? Cage is so 1935. You have to have a comprehensive assessment of alcoholism. And here are some of the questions that I've put that I ask in the ED. What do you drink? How much do you drink? How long have you been drinking? When did you start drinking? What time do you drink mostly? Are you drinking alone? Okay. How does the drinking help your mood at all? Do you feel relief? Do you feel more depressed? How do you feel in the morning after you've drunk your 30 units at night? Okay, are you having hangovers? Are you vomiting? Have you ever tried to stop? You know, what motivated you to stop the last time you stopped? Maybe we need to get you back to that place. Okay, what makes you feel like you're going to drink more? Did you start drinking at 30 units? I'm even not even looking at my slides now. I'm just, yeah. Did you start at 30 units or did you start at 2 units and did you feel like you're progressing right through or increasing your tolerance? Does it take more to make you get to the high of drinking? Okay. That's an alcoholic evaluation, guys. Now, has your tolerance increased? Are you regretful or guilty towards the amount of alcohol you consume? You just don't say, are you feeling guilty? Guilty about what? I feel guilty about, you know, crossing let me not say crossing the red light because maybe the police is watching this. Watching my lectures and they'll come to my house and say, you admitted online that you did cross a red light. I did not cross a red light. I repeat, I'm just making a simulation here. Now, has anyone been hurt as a result of your drinking? How often in the last year have you failed to do what was required of you because of your drinking? Are you missing out on important responsibilities because of your alcoholism? That's bad. I would not know. Don't say that because then you've already labeled them an alcoholic. Are you feeling that you're missing out on some important responsibilities because of the amount of alcohol you're taking? Okay. How often do you have a drink that contains alcohol? Now, I have to make a separate clause because I know some of you, your brains are absolutely magnificent in capturing information. And now you want to take all these slides and these 20 points and bombard your patient with it during the examination. You cannot do that and pass. It's a conversation. It's a dance. Okay? You need to be sensitive. So if the patient is showing you that she wants to talk about what led to her drinking, let her talk. It doesn't mean that if you ask all these questions, you're going to get full marks. Because somebody can tell somebody, as an examiner, you can tell a doctor who is not interested in a case and is just there to check boxes and pass. It's very easy to see a faker. It's very easy. So you have to build that vein or that artery of concern and compassion, all right? And I've been telling some people, I usually tell them, you know, where do you start? Oh, can you give us a book that I can learn how to improve my IPS? No, you learn IPS by being good to the people who are around you. You know, your poor wife, you've been studying for this PLAB for the last 1 year. You can't even make a little dinner for her. Oh, you're so absorbed by this exam, you've not called your mom. Talking to someone, you're leaving, your kids cannot even, daddy is reading, mommy is reading, she cannot be disturbed. What type of life is that? You can't fake kindness for an exam and pass. People will see right through it. And so your kindness has to start with those who are around you in your home before you take it out to the community. And that's why IPS is easier for some other people because their hearts are a little bit softer. Okay, and psych will trap you because you will see your personality. So even just stepping aside with this exam, don't let it consume you. I know you want to pass and you want to come to the NHS and you want to work, but don't stop living because you want to pass this exam. Anyways, how many drinks do you have on a day when you start drinking? Can you use just 5 powerful questions here? Pick 3, 4 of them and move on. Okay. Now, will you be asking questions for the whole allotment of time you have to manage? Because now what do you want to do? Do you want to tell her to quit taking 30 units at a go? I'm going to send you to the Alcoholics Anonymous and now you can start quitting. And you can, if she stops taking 30 units today, she's going to die tomorrow. It's too much. Her body is it's too much of alcohol for you to just stop. That heart is going to crash. So they are examining and assessing your capacity by, you know, hey, this doctor is just telling the patient they have to go and stop cold turkey today. No, you can gradually stop it. In fact, it would be best for you to be in a, where are we? Here we are. In a hospital or in a residential treatment facility to help you slowly reduce your amount of alcohol. And I said, you need to know the management for alcohol withdrawal. You can't just go into a case and not know how to manage alcohol. Alcohol withdrawal treatment, where are they on this spectrum? Do they have Wernicke's encephalopathy? Do you know how to diagnose Wernicke's encephalopathy? Confusion, loss of coordination, ataxia, nystagmus. Would you ask your patient these questions? You know, do you notice that even some days you're having problems with your coordination? Do you notice that sometimes you're a little bit confused, maybe forgetting things that are common, you know, to others, like maybe confused about where you're going, confused about your address, or forgetting important things? Do you have problems with your vision? 30 units a day for the last 20 years. Come on. That brain is the size of a walnut. Hypothermia, ophthalmoplegia. Okay. Dependency on alcohol, have to notify DVLA and agree to have their license suspended for a while. But before you tell somebody you need to notify DVLA, can you find out whether they drive? I do it in my mocks. The does, oh, you need to stop driving. Who told you I drive? I ride my bicycle, okay, that I bought with the PLAB money that I got, because my courses are too cheap. I can only buy myself a bicycle. So please don't just assume things. I'll talk about this alcoholic management in a few minutes. Anyways, medical treatment. What's your first choice with withdrawals? Benzos, okay. What if they have liver failure? Okay. Anti-craving medications. Do you have to list everything for them? I'm going to give you acamprosate. I'm going to give you naltrexone. I'm going to give you dalsalfiram. You have to learn how to dance. What is wrong with them? Do they feel like they cannot go without a drink? Okay. Oh, good. I didn't even think that I had this slide. Same Jane, found lying in the park and brought in by the ambulance. Jane was brought in by the ambulance. Oh, I remember from the recall. Oh, let me start doing an MMSE examination on this patient. Any patient brought in by the ambulance, it's time for you to do MMSE? Really? A patient has been brought in by the ambulance and you are the doctor in the emergency room? Why did the ambulance bring them to the emergency room? So that you can ask them about apple, table, penny? Get out. That's not being safe. Why have the EMTs decided to bring her to you? And if she is unsteady, what is the first thing that an emergency room physician does? Vital signs, blood sugar. Should be right at the tips of your fingers, guys. Please, 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 please. A patient who is unresponsive. Why are you checking vital signs as the first thing? Patient is unresponsive. I want to check the responsiveness of the patient. We have already told you, oh God, we've told you the patient is unresponsive. You want to check responsiveness again? We've told you they're unresponsive. Patient is unresponsive. What do you want to do first? I want to look, listen, and feel. Get out. You need to stabilize the airway. Again, can you dance? A patient who is unstable, he breathing, I can't, I'm looking around all the, do your vital signs and blood sugar. But if that patient is not responsive, it's not time for you to do GCS. It's not time for you to, I need to expose the chest and listen to the lung sounds. An unresponsive patient, the thing that should roll off your mouth is airway. Please. And as a junior doctor, you need to know how to manage an airway. It's not calling for the anesthetist. What the anesthetists are now stuck in ITU proning patients. So the patient is going to die because you do not know how to manage an airway with an airway adjunct. Too sad, too sad. This actually for me has stopped being about teaching the PLAB. It's no longer about teaching the PLAB. It's honestly making good companions to work with me in the NHS, because I can't tell you how many times we've people fail in management of simple diseases. I see it so many times in my mock exams. Easy things that are critical people fail because they are too focused on passing an exam. You can't take that attitude with you into a working place. You will not succeed. You will not succeed. So Samantha Jones or Jane Smith, she's been brought in by the ambulance. You walk in, her face is wet, she's sweating. All right, she's having nausea. Doctor, can I have something to vomit in, please? All right, what is all this? What are all these things that are going? Alcohol withdrawal is quite significant, guys, in the way it presents. Sweating, tachycardia, nausea, there's a tactile disturbance, they have numbness, they're anxious, they have auditory disturbances, they have tremors, they have a headache, decreased orientation, they may be agitated. If you have a patient who is demonstrating symptoms in multiple organs, you want, okay, their mind is affected, their heart is affected, their skin, they are feeling like they have a rash, their breathing is, I want you to be very broad in terms of thinking of substance abuse, or they could be withdrawals. And now, if I can think up a case of alcohol withdrawal, can I bring another case, cocaine withdrawal or cocaine intoxication? What's the difference? Which pinpoints are, which pupils are as large as Coca-Cola bottles? Cocaine, okay? So you need PCP, LSD, you need to research in these things. If I was to teach psychiatry, it would take me 3 days. There's just too much to teach. Okay, so now I'm making this as a trigger for you. Acute alcohol withdrawal, go and study withdrawals of all substances, okay? And intoxication of the same substances, because they're all in spectrum, okay? Which substance will have the patient with diarrhea, vomiting? Well, diarrhea is usually very specific. Stomach upset. Which one is it? Is it cocaine? Is it heroin? Go look it up, please. I can't be giving all the answers here. I want you to also invest in the study. Now, there's this wonderful, wonderful thing that you must know, not even for the PLAB. It's called the CIWA score. Clinical Institute Withdrawal Assessment for Alcohol. It's in every NHS. And if you are a doctor and a patient has come in and you're suspecting alcohol withdrawal and you don't do the CIWA score, you'll be in trouble. You're going to have a meeting with the board. It's first line for withdrawals of alcohol, and that's why I want to discuss it now. Are there other withdrawal assessments for other conditions? Yes, look them up, okay? Now, nausea and vomiting, they get a score, okay? Tremors, they get a score. Paroxysmal sweat, nighttime sweating, they get a score, okay? And if they're sweating, are they coughing? And if they're sweating and if they're having nighttime sweats and they're coughing, will I give them a test to check for TB? Yeah, maybe. I'll do a COVID test first. Anxiety, agitation, tactile disturbance, auditory disturbance, visual disturbances, headaches, orientation. A score less than 8 indicates mild withdrawal. In my hospital, if they have a score more than 15, in fact, our cutoff point is 11. If they have a score of 11, you automatically prescribe. I want vital signs for this patient every hour, okay? I need to prescribe diazepam 5 to 10 milligrams, okay, according to the CIWA score, all right? If unable to tolerate oral, give IV. Oh, there we go, good. We hardly do CPZ, no. We go right to diazepam, okay? IV Pabrinex, 1 to 2, what is Pabrinex? Pabrinex is like a banana juice, it's like a banana bag. Thiamine, everything that you know an alcoholic might be missing electrolyte-wise is in that banana bag, but it's mostly thiamine. IV Pabrinex, okay, 1 to 2 TDS for 3 days, and then thiamine 300 milligrams OD, okay, vitamin B compound strong 2 tablets TDS. But the big one here is your Pabrinex, IV diazepam, and your vital signs, and putting them on a CIWA score, which is assessed. Sometimes they may assess it every half an hour, and this patient has to be on a cardiac monitor, please. Alcohol withdrawal delirium, okay, it's a little bit different. A patient can progress from AWS to AWD. That's why our vital signs are every hour or every half an hour, okay? Now, these are different blips, blah, 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 blah. Oral diazepam until sedated. If unable to tolerate the oral, we give the IV, okay? We need to watch for liver impairment with alcohol treatment, please, because if they have a liver impairment, you have to switch to the lorazepam, as I had mentioned before, okay? And of course, talking to your seniors, but CWA score is a very important thing for you. Don't be the doctor who comes to the NHS and you're hearing CWA score on the first day of work. Where did you train? Okay, now, these are the eating disorders. They're really, really, really not bad. So a patient has come in, she's been brought in by her parents because she's not eating, and I should have said increased weight loss. Yeah, increased weight loss. Again, all right, some of the questions I've kind of highlighted here for somebody who is having anorexia. What insight do they have about their weight loss? Do they think they've lost weight? Because then now you need to know, are they in denial? They're in denial, then at least we need to get them to a place of acceptance, because only after acceptance is when treatment is going to be progressive for them. That's where we see good outcomes, when a patient starts to accept. Sometimes the acceptance may need to be given to them with, on a platter. Okay, so Samantha Jones has come into the hospital. She's 16 years old. She's been losing weight. You go to her, hello, Samantha, my name is Dr. X. I'm one of the juniors in this department. Yes, doctor. I was just going through your notes. How is your health? I'm fine. Okay. When was the last time you went to the GP? It was about, I can't remember, maybe 3 years ago. I don't even know. I don't keep tabs. Who brought you in today? Well, my parents brought me in. Where are they? Are we waiting for them for this consultation? I don't know. I don't care. She's 16. So I expect her to act like a 16-year-old who doesn't have manners. Okay. All right. Usually before I start any assessment on a minor, it's important for me to get permission from the parents. Very critical thing, guys. You can't just start treating a 16-year-old without at least mentioning that. I'd like to speak to your guardian or to your parents just to make them aware that I am the treatment doctor on the team, and I'm the one who's going to be asking you a couple of questions. Usually we want parents of minors to be in the same room when we are doing examinations for minors, except sexual health. Okay. All right, so Samantha, what year of school are you in? I'm just about to graduate high school. Oh, that's very good. How are you coping with the COVID? I'm doing okay. Are your classes online, or are you still going to school using social distancing? Well, I'm going to school, just mixing it up. Okay. How are your studies? Are you getting good grades? You see, psychiatry, that's what they do. Well, I'm getting good grades, doctor. I'm trying my level best. Okay. Health-wise, so I'm reading through the notes and I can see that you've had changes to your weight. No, doctor, I'm fine. Do I look skinny? How do you respond to that? Do I look skinny? If you say yes, if you say yes, you look skinny, you'll get into trouble. If you say no, you don't look skinny, you'll put yourself in such a hard point by telling her she's losing weight. You told me I don't look skinny. So now how do you answer that? It's quite a social question. You want to say, well, when it comes to a consultation, words like skinny are quite relative. We don't use skinny or fat to diagnose conditions. There's what is known as an unhealthy weight, and it is usually outside a range of 18.5 to 24.9. So 18.5 to 24.9, what is known as a BMI, body mass index, where we're comparing your height and your weight. Okay. You're out of these parameters, then the weight is unhealthy. But it doesn't mean that you can stay in unhealthy weight as a permanent situation. It's quite very fluid. Okay. So how much do you weigh? I weigh 45 kilos. Okay. And how tall are you? I'm about 6 foot. Okay. So just from that, there's a bit of a discrepancy with your height and your weight. And you feel okay? Yes, doctor, I do. Do you eat regularly? What do you eat? I eat, chips and fish, and I eat samosas, and I drink milkshake. So now you're thinking she's eating, she's having a good intake, but where is there an excessive output? Okay. Or she is not eating at all. She's restricting her intake. Or she is eating and if she's not vomiting, then she's probably using some wonderful wonderful laxatives that are helping her to lose the weight. So you always have to think in that dimension. Okay. I would even ask for thyroid problems. Okay. I've put here famish because I hear people telling me about famish all the time. Do you have friends? How is your family? Do you take alcohol? Do you have any medical illnesses? Can you first focus on the weight? That is the chief concern. Chief concern, and then rule out your medical conditions and then give her insight. Samantha, you're telling me that you are eating only an apple a day with 6 glasses of water, and you're on the track and field team running 100-meter feats, every 3 days, or you're in the gym for about 6 hours a day. An apple maybe has about 2 calories. Water has 0 calories. It doesn't add anything in terms of nutrition. Okay. But when you're in the gym working out on the ellipticus, or whatever it is, you can tell I don't use the ellipticus, it's too complicated for me. The elliptical or the ellipticus, you're burning almost 500 calories per hour, and you're there for 3 hours, but you're only eating 2 calories. Do you see the discrepancy? Do you feel dizzy sometimes? Do you notice that you're losing concentration, getting a bit confused, any tremors in the body? Because if she's been eating an apple a day for the last 2 weeks, well, we're thinking that, nutrition, she's gone. Now, this poor girl, are you going to send her to an eating disorder clinic and she's been eating an apple a day for just for 2 weeks? She's 45 kilos. Because I have such a big hard time with people when I'm doing an anorexia case with them. Eating disorder clinic. Did you find out whether her weight loss is due to diabetes? Polyuria, polydipsia, polyphagia? No. All you know is somebody has come in with decreased weight and automatically it's anorexia, and you're asking her, what type of clothes do you like to wear? You could be anorexic and wear very fashionable clothes. Quite a redundant question to ask. I don't know where people get that question for. Do you have any role models like Victoria Beckham? I'm like, what? Victoria Beckham, who? Golly, she's so 19 and just in case she watches these videos, we love you, Victoria Beckham. Okay, you can't just ask people if they have role models and if they're trying to be like it. The thing is the insight. Does she understand her intake is infinitesimal amount? 2 calories and her output is almost 1,000 calories. And is she passing out and having dizzy spell? Admit. You don't even need to have a BMI to admit. And that's why I put stars on these things, because people just say, if it's less than 17, I'm going to send her to the eating disorder clinic. Less than 17, you want to send to an eating disorder clinic that's open from 8 to 5? Less than 17. I want to at least keep her for a couple of hours. Let her speak to a nutritionist. Do we need to supplement her with IV fluids? Come on. Can we check her cardiac function? Can I even just run an HbA1c? Let's make sure she's not diabetic. Okay. Other things, thyroid function test, ECG is absolutely important. Now, she's 16 years old. The word anorexic has a very poor connotation in the world that we live in. It's almost abusive. And that's why mental health is quite difficult in this country. You're anorexic. Oh, you are abusing me. I'm not anorexic. You have an eating disorder. As per what you have told me, you're having a hard time gaining weight because you are restricting the amount of food that you are eating. or you are having a hard time or a challenge gaining weight because you are eating adequately, but you've told me you are feeling sick afterwards. Okay? Or you are having an eating or problems with your nutrition, your input and output, because you're eating very little and you're using a lot of it with your exercise. We need to come to the center or to the bottom of why you're doing this, okay? It is not healthy. Do you understand that it is not healthy to continue in the pathway that you are going? Do you understand this, Samantha? Your body is now working on reserve tanks, and before long, and in a couple of days, you may not be able to sustain yourself with this habit. I'm concerned. We may need to talk to your parents about this. You know, I want to see how much support they are willing to give, and it is my recommendation for you to be admitted in the hospital. You have not been eating regularly for 2 weeks. So if you go home and start eating large meals, you could get into what is known as a refeeding syndrome, where there are rapid shifts of electrolytes like potassium in the body, and this can affect the heart. So we need to gradually get you back to a healthy level of nutrition. You told me you're in high school. You told me you want to be a lawyer. It takes a lot of glucose to process some of the things that you're studying in school. Let us get you to a healthy weight. As part of your physical examination, you want to verbalize. Don't just be the doctor who says, I want to check you from head to toe. Head to toe what? Please. I haven't said please in this video. In all my videos, at least I say please 3 times. Please, please, please. Head to toe examination. You're going to do tympanics. You're going to do an oral exam. Are you going to now start getting the foot exam and sensation? Are you going to do a full exam? What if the simulator says, go ahead, do a full exam? You've trapped yourself with your words. No, I need to do a focused examination. Just check your body. You know, sometimes the bones are affected if the nutrition is off balance. I just want to feel some of the power in your arms, okay? You can even test to see if you have brittle bones. You can do some blood tests for that, okay? Sometimes with poor nutrition, some people notice a very fine appearance of hair on the body, especially the back. I want to check on that. Kindly let me just feel the glands around your face. Why? Because now you're realizing she lied to you. She's eating this much food. She's refusing to say she's vomiting. And her BMI is 15. She's eating food, but where is it going? Where is it going? And now you can't just say, I need to check to see if you're vomiting or if you're binging and then you're barfing afterwards. If you would permit me, can I just look at your knuckles? Okay, I want to see if there are any skin changes. I need to feel around your cheek areas. Sometimes the glands around the face can swell in response to the eating imbalance that you're having. Parotiditis, yes. And then I may even need to just check your teeth. What if the examiner tells you there's an eroded teeth, the knuckles are rough, and the glands are swollen? You want to say this combination of symptoms or assessment, I have a high suspicion that you are maybe vomiting after you eat. I'm very sorry, I have to be truthful, but that's how you deal with this case, guys. This cough thing, famish thing, you have to be very, very careful. Goodness. Does food dominate your life? Get out of here with all of that. You need to now know, okay, I've taught you this anorexia nervosa, bulimia, treatment is SSRIs, but you have to be very careful with bupropion, okay? So this is a nice Venn diagram, okay? Because now in bulimia is a binge eating, the treatment is also psychotherapy. They may have a normal or high BMI. They may be having signs of purging and vomiting. Anorexia, they can have signs of purging and vomiting also. Binge eating disorder, they can have a high BMI they may have binge eating, but binge eating is because of the treatment is psychotherapy. Okay. Be very, very careful in psychiatry. I really hope even as I wind down, that you'll be able to manage these cases quite effectively. You may have a patient, and we even dealt with this last time, a patient who is admitted to the hospital. Okay, let's just go through this case. In your effort in the AMU, 27 has been admitted. They're a known drug addict, and they're now diagnosed with urosepsis. She's fighting with the staff and wants to go home. Talk to the patient and address her concerns. So I've put two cases in one. One could be a drug addict, okay, who is having withdrawals and they want to go home. Or there is another one who has urosepsis and wants to go home. Why? Why does she want to go home? I want to go home because Amazon is coming tomorrow morning and I have ordered the Bowflex machine or whatever. Okay. Aggressive patients, dealing with them in psychiatry, first of all, you want to show that you are maintaining a safe environment. The patient is talking to you at this level, a very high, intense level. You don't want to be talking when they are talking. You want to take a step back and you want them to speak. And after they speak, you want to tell them, okay, I can see that there are very many things that are frustrating you. Okay. And then recap. Because let's say you walk in, Samantha Jones, I don't want to be here. I want to go home. I hate this hospital. They are keeping me against my advice. Blah, 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 blah. Bombarding you. You're not going to start saying, no, we don't know. You're not going to try and pipe in because she can't hear you. After she finishes talking, then now you want to say, okay, Samantha, kindly let me reintroduce myself. My name is Dr. X. I'm one of the juniors in this department. I can see that you're very frustrated. And I'm sorry, if I knew you were this upset, I would have come a little bit earlier. Okay. Thank you for letting me know what is happening. I can clearly see you do not want to be here. Okay. Can you give me just a few minutes to understand what is going on so that I can better manage your care? And if there is no reason to keep you here, by all means, I will prepare the paperwork and we will discharge you. I even want to make sure that you're medically fit to go home. Can you give me a couple of minutes? Can you give me 5 minutes? Of course, if I'm in a 10-minute station, I'd be like, can you give me at least 10 minutes to assess what is going on? And if at the end of the assessment, if you're not happy with what I have to discuss with you about, then absolutely you can sign out against medical advice. Okay, doctor, I'll give you 10 minutes. Good. Now, since I was looking through your notes and you have been diagnosed with urosepsis, which is an infection in the bladder. Now you need antibiotics. Did anybody explain this to you? Okay. This is different from a regular urinary tract infection. It means the urinary tract infection has progressed to the blood and now the bacteria is in the blood. Because you've given me 10 minutes, is it okay, even as we discuss, let us save this, let us utilize this time. Can I have the nurse hang up the antibiotics so that it's infusing during this conversation, at least so that you can get a little bit more management for the condition that you're having? She's given you 10 minutes, guys, use it. At least we can get more antibiotics into you. Why do I have to take IV antibiotics? Give me oral antibiotics. Unfortunately, and let me just give me a little bit of more time to explain this, is because if we give you an oral antibiotic, the pathway to the blood is very long, okay? And in the pathway to the blood, it is the potency or the efficiency of the antibiotics is literally cut in half, okay? So that by the time it gets to the blood, okay, half-life, by the time it gets to the blood, it is not as effective as it is for the infection. Urosepsis can cause organ damage. And now we're not even dealing with the bladder anymore, but we're now looking at organs like the liver, the kidneys, the heart, and sometimes it can even affect the brain. The body starts to shut down. Your blood pressure starts to go down, okay? And because the blood has a lot of nutrients for the bacteria. So the bacteria is really proliferating. Now, on the other hand, if we give you an antibiotic through an IV line, it is going to go straight into the blood and help eradicate the bacteria faster. Okay. Now, guys, why did I start with management in this case? She wants to go home. Okay. I've just touched about her condition with urosepsis. All right. I've told her what she has in a pinpoint manner, like directly to the point. You just had a heart attack. This is what happens in a heart attack. The tissue is dying. If you go home, there is probably no management we can give you. When you go home, you need to be evaluated. What caused the heart attack? Are your vessels clogging up? You can't just take an oral pill to help a condition that is in the blood or that is causing end organ damage. All right, give the management first, and then now you can go back and get a little bit more history. Same thing with the drugs. The patient is scratching themselves. I can see that you're quite uncomfortable and you're scratching yourself now. Do you notice this happening? Okay, do you notice this happening when you haven't taken the drugs or when you haven't taken your heroin? You know, you're in the hospital now. We can help you with these withdrawal symptoms. We can give you some medications to help with the withdrawal, because maybe she wants to go home so that she can take the drugs. Now I'm scratching it also. Now, if you're in an examination that has an alert system to tell you you have 1 minute left, you have 2 minutes left, you have 3 minutes left, and you've been fighting with an aggressive patient who wants to go home and they don't want to listen to anything that you have to say, you have to realize that this case is unresolvable and your last 2 minutes has to be more management of what they need to do when they go home. Is she refusing to stay in the hospital? You have not convinced her in 6 minutes. How will you convince her in 2? You want to move it on. You have to sign some documents to say that you understand that it is not in your best interest for you to go home. But when you go home, I would like to know if you have somebody to take care of you who can call 999 in case you collapse because of an overwhelming infection. In case you become, the mind or the brain becomes affected, you have to give safety netting, guys. You have to give them alarm symptoms. I have a good time with this aggressive patient case, even to a point, of saying I'm going to leave, and I take my bag and I walk towards the door, and the doctor goes towards the door to barricade me. Never put yourself in a position where you can get clobbered. You always want to maintain your distance. If the patient wants to walk out, by all means. And now if you're in a situation where the patient is aggressive and they're standing up, you want to be sitting down in that exam? If a patient is standing up, you mimic them. You have to mimic behavior. Okay. But now with this case, would you now start, do you travel? Do you exercise? What did you eat for dinner? Throw all that stuff out. Throw all that stuff out. Okay. I know I've been going on quite a bit with some of these psychiatric cases, but I really wanted to make sure that you have a good idea of what is going on. I want to make sure that you no longer just go in to gather data. I don't want you to do that. I want to make sure that at least you can expand your knowledge base. You can expand your data gathering skills. You can focus also on your IPS. Okay, you want to really make sure of these things. I'm looking for one more case here. Let me see if I can get it. I wanted to talk about suicide. As I said, I would talk about it before we end the session for today. So let me get that case, and I want to do a suicidal assessment risk. So let me share. Of course. Hold on 1 minute. Let me just get the slide and then we shall return. Just give me a minute. Okay. Suicide assessment risk. Samantha Jones has been brought in by the ambulance. She stabbed her femoral artery and she's bleeding out. She has been stabilized by the medical team. Now you've been called as a psychiatry SHO to come and assess her. My name is Dr. X. I'm one of the juniors in psychiatry. I've been told to come and assess you as a recommendation by the medical team. I was just going through my notes, Samantha, before we can go, move further. Can you just confirm your full name and your age? If you forget to ask identifying factors, don't feel bad. Do it as soon as you can. Okay, it's a safety thing. You don't want to be talking to somebody and then you find out, no, my name is Mary. Who's Samantha? I didn't stab myself in my groin. Okay. All right. So my name is Samantha. I'm 25 years old. Yeah, okay. So can you just give me an account of what happened today? My boyfriend left me, so I tried to kill myself. I'm quite sorry that you made an attempt at your life today. Is this the first time that you have done this? How are you feeling about the whole ordeal? Well, I don't care anymore. Nobody loves me. I'm just useless. This is the 5th relationship I've been in. Now I'm just, I can't handle men anymore. A lot seems to be going on in your life right now. Do you have any support? Psychiatry. Do you have, who else do you live with? Are you alone in Manchester? Do you have friends? What do you do for a living? Where is your immediate family? Okay. I can see you have a very big burden to bear and you've been bearing it for such a long time alone. Okay. And today, just according to the note, I can see that you had an injury that has been stabilized by the medical team. Are you feeling dizzy right now? Are you feeling palpitations? Are you feeling weak? The area that that was injured is quite significant in terms of blood loss. So even as we are managing you in psychiatry, we have to make sure that you continue to be medically stable. You can even just walk out of the case and say, I know I've passed. I know, give me my 20 points. I know I've passed this station. Why? Your mind is so broad. Yes. How can a patient come in with slit wrists and as you don't even mention anything about assessing them or even offering pain meds? Or because I'm in psychiatry. Psychiatrists don't do that. They are the most compassionate people. Even their offices, they smell nice. Of course, I'm saying it from experience from watching movies. I don't know. I can't say my biases in this session because maybe some people are here and they do need psychiatric help, and we need to remove the stigma behind seeking for psychiatric help. And most of the times, the ones who need the most psychiatric help are physicians. Why? The highest rate of suicide, guys, is from physicians. What is going on? We've worked so hard to get to where we are, a career that takes a minimum of 15 years. And then you get to a point where it doesn't make sense anymore. And that's the danger of having a false perception about this career. It's not easy. It's not. It's a career of sacrifice. You can't come into it for the money, and I know you know it. Okay. So now you have a patient in front of you who has made an attempt in their life. You cannot be robotic. You cannot be scripted. You have to dance with them. If you walk in and they don't want to talk to you, you want to say, I can see you are hesitating to open up. Do you need me to give you some time? This is a sensitive matter, but I am here for you, okay? I am here for you. And I am glad, Samantha, that you made it today. Your intention maybe could have been to end your life, as I'm reading from the note here, but I'm glad that you survived, because with every survival, there is a chance for hope, there's a chance for something better tomorrow. And if you can open up to me, I will really appreciate it, because now I can find out what went wrong, what triggered this whole occurrence, how we can keep you away from the triggers and keep you motivated towards living one day at a time. I'm not asking for much. Would you like me to call anybody for you? You see, that's a conversation I'm literally having with the room, because if Samantha doesn't want to talk, you can't start saying, everything that you share with me will be held between me and the team. Who cares about you and the team? I don't care about my own self. I wanted to kill myself. You think I'm caring about you and your team? Guys, you have to be compassionate, try and figure out the whole story. Your listening skills have to be so clear, because in suicide assessment risk, clarifying information is redundant. Or just to clarify, you were in the bathroom and you stabbed yourself in the femoral artery and you used alcohol and you took paracetamol. Just to clarify, weren't you listening to the first things that she said in the beginning? I was in the bathroom and I took a packet of paracetamol. How many did you take? Did you use alcohol? What a question. You need to use, what did you use when you were to swallow the pills? Not everybody's an alcoholic. Then you can ask, did you use any other substances? Let her tell you alcohol. Okay. Did you take any other pills? Because some people just surrender. I heard she takes paracetamol and that was it. No. Did she take paracetamol? Did she take any other medications at all? And then you ask, what is your expectation? Rubbish. Absolute rubbish. Okay. Who found you? Do you remember any events after you took the pills? Did you feel sleepy? Did you vomit at all? Are you the one who sought for help, or did somebody call the ambulance for you? My mother was in the house. She called the ambulance. I'm glad that she was there. That's where you're throwing your IPS. Okay. All right. Can I ask if you wrote any letter at all? Did you write a note? Do you have the note? Do you mind if I take a look at it? I don't want you to read it. Okay. So if we were to try and point out the main trigger as that led to this event, you would say it's the departure of your husband? Yes. I don't know what to do now. Well, there are very many other men out there. You will find somebody. Stop. I'm giving you feedback from my mocks and what I hear people saying. It's quite redundant. Okay. Now, what are your thoughts about surviving? Are you happy? Are you seeing my face? If I had a mask. Are you happy about surviving? You have to use your eyes, your head, and of course, you're not just going to show that you have like tics. The patient is going to ask you, what's wrong with your head? You know? No, or like all the way. Do you have a neurological disorder, doctor? No. What are your thoughts about surviving? I regret it, doctor. I feel like I can now face life and it'll never happen again. And then you discharge them. Tomorrow they'll come in a body bag. The most manipulative person in psychiatry is the patient who has attempted suicide and has survived. And if they get another chance, they will do everything to convince you to leave them alone so that they can do it again. You cannot discharge anybody who has attempted their life without a senior review, even if they tell you all the beautiful golden words that they love life, they have kids, they have a career, it will never happen again. That is not a reason for discharge. Okay, please. Outlook on life, thoughts about surviving, okay? Then you have to gauge, is it appropriate for me to ask medical conditions? Maybe. But I want to dig deeper into any other cause of why her mood was so low. And has she been low to this point before? Is this a second attempt? What does she do usually to cope with a hard time? I would like to go there. Traveling, diet, exercise. Do you smoke? Do you drink? Or just to review your whole body system, I have to ask you a couple of questions. Do you have any allergies? I'm allergic to your type of doctor. I'm allergic to you, Dr. Lian, because that's a very crazy question. Please. Okay. Now, would you try to hurt yourself again? Whether the answer is yes, no, maybe so, you're going to be with us for the next couple of days. We need to really make sure that you will be safe to go home. Okay. I would like you to talk to my senior. He may ask you the same questions again. We just want to make sure we are getting the story straight and finding out if there are any other hidden triggers that could have made you get to such a low point in your life. You know, Samantha, we are meeting for the first time, but I'm glad that you survived today. And I feel hopeful that, you know, if we get to the bottom of this, then you can lead a productive life and you can learn how to cope with anxieties and depressions and the stresses of this life. Because many people are going through a very hard time during this season. And ending your life is really not the answer. Okay? Now, here is the thing. One who takes his life dies once. Those who are left behind die 1,000 deaths. Why I came across this and it really hit me because I said, it is actually true. And it's just something for just us to think about, even with the stresses of being a physician. And maybe who knows why you may be listening to this lecture and landing at this point in time of the lecture. Okay. The answer of taking one's life away has to be investigated with a team. It's not a one-person thing. You want to be very careful about saying, I need to refer you to the psychiatrist. You may want to say, I need you to sit down with a specialist who can evaluate with you, sit down with you, talk about it, understand you and why you made this decision, and try and help guide you to make a better decision in the future if you ever find yourself in such a tight space. What if you get a different patient who had attempted suicide a couple of days ago? Now we've assessed her, she's going home, we need to do a review. What kind of questions would you ask her? I would try and ask her, you know, it's important for me to know the triggers that led to the suicide, okay? And to know what coping skills have you learned during this, or have you added to yourself during this admission? And anybody who is going to be discharged, at least you can give them the hotline numbers and all these other things. Or even in this case, if you're going to admit them, you can still mention that, you know, and when you're well to go home, I would still want to be able to safety net and make sure you'll be okay. And if there's a time you feel that you are really, really depressed and really discouraged, I'll give you a list of numbers and contact information for you to call. Please remember, we all go through hard times. Things may look quite depressive now, but be hopeful. They may change for the better with time. Okay, if you encounter anything too difficult that you cannot deal with and find yourself contemplating suicide, please give yourself a chance to talk to someone. One who takes his life. I once heard from one of my teachers, a doctor who came from the villages in Kenya, and she said, one who dies once, so takes his life, dies once, but the ones who remain are the ones who die 1,000 deaths. So this decision to leave Samantha is not only for you, but also for the ones you love. And now things may seem gleam or gloom, okay? But we are here for you. Do not discharge a suicidal patient. If at all you have not gotten anything in this whole session, that's one thing that's a take home for you. Okay, so I'm glad that I was able to do this session. At least I've been saying to myself I should try and put out a new video every now and then just to help the doctors practice for their various exams, especially the PLAB too. And I'm hopeful. I'm hopeful that things will change for us. I'm hopeful that maybe one day this lockdown will be eased and people will be able to travel and come and realize their dreams in the UK. Okay, so thank you for joining me for this session. As usual, my sessions are usually 2-3 hours long. Okay, but I want you to remember, if you're in psychiatry, you are the voice of hope in the darkness. creating a path towards the sun. If at all you have a psychiatric scenario before you, you have to step back and take your time to guide these patients. It's not about the medical, it's about touching that heart and trying to make a difference for that patient with whatever time that you have. Okay, until next time, I shall see you and have a blessed, blessed night.